Good morning, I am Dr. Henna. My topic for presentation today is dermoscopy. A brief introduction about dermoscope. Dermoscope is a non-invasive diagnostic tool with inbuilt illumination and magnification sources. It is also called as dermatoscope, skin surface microscope, epiluminescence microscope or episcope. It helps in visualization of skin surface and subsurface structures which are usually not normally visible to the unaided eye. Initially, it was devised for the diagnosis of pigmented lesions and melanoma, but now it is widely employed in non-pigmented lesions including non-melanoma skin cancers, inflammatory dermatosis, benign skin tumors, etc. Next. Into the history of dermatoscope. Johann Saphier was the first to introduce the term dermatoscopy in 1920. He was the first to employ a device similar to binocular microscope that had an inbuilt light source for skin surface microscopy. Goldman coined the term dermoscopy in 1950 and advocated its use in the evaluation of pigmented skin lesions. Then dermatologists from Ludwig-Maximilian University of Munich in collaboration with Hein Optotechnik developed the first handheld dermoscope in 1989. Trigen, a California-based medical device manufacturer, introduced first polarized handheld dermatoscope in 2001. Next. The device. So a dermoscope has four essential elements. First is illumination system, then magnification, power supply and image capture. Illumination system consists of LED lamps which may be polarized or non-polarized. Magnification is provided by specialized achromatic lenses. In a conventional handheld device, the magnification is up to 10 to 20 times, whereas in a video dermoscope, it is up to 400 times. Power supply in handheld devices, it is by lithium-ion batteries, whereas in video dermoscope, it is through power cord connected to an electric supply. Image capture in handheld devices, there is provision to attach digital cameras or mobile phones, whereas in video dermoscopes, it allows capturing screen contents as digital images. Then recent advancements in the device include pigment enhancing LED lamps, autofocus lens and device with image storage and analysis software. Next. Coming to the physics and optical aspects of dermoscope. The basic principle of dermoscopy is trans-illumination of a lesion and studying it with a high magnification to visualize subtle features. So, the light which is incident on skin may undergo reflection, refraction, diffraction and absorption. This is influenced by physical properties of the skin. On a dry, scaly skin, the light incident on skin is mostly reflected. This is due to the difference between refractive index of stratum corneum, which is 1.55, and air, which is 1. Whereas on a smooth, oily skin, it allows most of the light to pass through it, reaching the deeper dermis. So this principle has been used this is the mechanism behind the use of linkage fluids. Next. The fluid medium between dermoscope and skin surface with the refractive index closer to that of stratum corneum is used to ensure enhanced penetration of light into the skin. These fluids are called linkage fluids. Most commonly employed linkage fluid is ultrasound gel. Others include oils which are immersion fluid, olive oil or mineral oil and glycerin. And if nothing is available, water can also be used. Glass has a refractive index 1.52 which is similar to that of skin and hence when placed over oil applied skin further enhances trans-illumination of the lesion. Next. So this is an image showing the optics of dermoscope. The refracted light trans-illuminates the lesion while passing through it and this is perceived as a distinct pattern. Next. Coming to the types of dermoscope. Dermoscope can be classified depending on various criteria. Based on the part of the body assessed, it can be onychoscopy, trichoscopy or mucoscopy. Onychoscopy for nails, trichoscopy for hair and mucoscopy for mucosal lesions. Based on the structures assessed, it can be trichoscopy or nail fold capillaroscopy. Trichoscopy for hair again and nail fold capillaroscopy for the capillaries on the nail to detect abnormalities in the capillaries of nail fold. Then based on categories of skin disorders assessed, it can be pigmentoscopy for pigmentary lesions, inflammoscopy for inflammatory skin lesions, and endodermoscopy for skin infestations and infections. Next, based on the device, it may be handheld or it may be video dermoscopy. Based on illumination mode employed, it can be polarized or non-polarized. And based on techniques employed, it can be either contact and non-contact dermoscopy. That is, if there is direct contact with the skin, it is called contact dermoscopy. And if there is no direct contact, it is called non-contact dermoscopy. Contact dermoscopy has a risk of contamination, cross-contamination. So this can be bypassed by the use of plastic covers or cling film, which prevents cross-contamination. Then another classification based on the techniques is dry and wet dermoscopy, depending on the use of interface fluid. If interface fluid is used, it is wet dermoscopy, and if it is not used, it is dry dermoscopy. Next is briefly about polarized dermoscopy and non-polarized dermoscopy. In polarized dermoscopy, it has a source polarizer, detector polarizer, and light detector. The source polarizer polarizes the light. A part of it penetrates into the skin at variable depths and undergoes scattering, and remaining gets reflected. The detector polarizer allows only scattered light to enter the light detector. So it totally cuts off the surface related light. So by minimizing the surface glare, it provides clear visibility of deeper structures up to 100 micrometer deep. For example, collagen, blood vessels, infiltrates, dermal pigments, etc. Next. Now coming to non-polarized dermoscopy, mostly reflected light from the surface enters the light detector. Hence surface features like rugosity, papillary projections, and structures like scales, follicular openings are clearly visualized. So this is the picture showing non-polarized, polarized and pigment boost of dermoscope. Coming to dermoscopic analysis, it involves description of features and interpretation of the features. So description of features include basic structures, patterns and colors. Structure is a morphological element with definite shape and size corresponding to a histological or clinical feature of the lesion. This can be seen in different morphologies and patterns. Areas without definite shape and size but form patterns are called as structureless areas. Patterns are actually formed by repetition of structures. Next. Colors. Colors are determined by three basic chromophores: melanin, keratin and hemoglobin. Color contrast can be attributed to admixture of chromophores, level of their situation and the biological state of the chromophores. In addition to these chromophores, colors may also be due to other phenomena. For example, white color can be due to dermal fibrosis or amelanosis, whereas black color can be due to thrombosed capillaries. Structures, patterns and colors in combination, when consistently associated with a diagnosis, forms the dermoscopic diagnostic criteria. Also look for follicular and perifollicular changes, vascular patterns and other diagnostic clues. Follicular changes may include dilatation, occlusion, plugging, etc. Whereas perifollicular changes may include erythema, scaling, pigmentation, etc. Vascular patterns, if only a single vascular pattern is seen, it is called monomorphic, whereas multiple vascular patterns, when seen in a lesion, it can be called as polymorphous. Next. Coming to interpretation of dermoscopic features, identical patterns may be found in multiple related or unrelated disorders. So, interpretation should always be performed in the light of clinical picture. If dermoscopy yields non-specific findings, along with clinical histological correlation may be required. So this is a table showing the basic structure, morphologies, patterns and distribution. So the basic structures include lines, clodes, pseudopods, dots and circles. Lines are solid structures with length exceedingly more than width. It may show different morphologies like thick, thin, straight, curved, etc. and patterns may be reticular, parallel or branching. Then clots are solid objects with definite size and shape. It can have morphologies of globules or lacunae and may show a globular pattern. Pseudopods are clots with bulbous extension at the margin. It may show circumferential or segmental pattern. Dots are solid objects which are smaller than clots. It may be fine or coarse in morphology and may show uniform or non-uniform patterns. And circles, solid ring-like objects whose margins are equidistant from the central point. It may show morphologies complete, incomplete, interrupted, and in pattern it may show concentric pattern. Next. So this is a box which shows the images describing lines, clots, pseudopods, dots and circles. Next. So this shows the schematic representation of colors in dermoscopy. If keratin is non-dense, it may be white. If it is dense or contaminated, it may look yellow. And if it is mixed with serum, it may look orange. And mixed with oxygenated blood, it may look red. And mixed with deoxygenated blood, it may look blue. And melanin, if it is in stratum corneum, it will look black. In malpighian layer, it may look orange. In papillary dermis, grey. And in reticular dermis, blue. Hemoglobin, if it is oxygenated, it may look red. And if it is deoxygenated, blue. Next. These are the schematic representation of vascular morphologies. It may be straight, curved, spiral, dotted, etc. Next. Coming to the uses of dermoscopy. Dermoscopy can be used to diagnose skin lesions. It can refute a diagnosis, or at least it can narrow down the differential diagnosis, list of differential diagnoses. Then it is used in the monitoring of skin lesions and response to treatment. Dermoscopy can be used as a tool to monitor for serial monitoring of skin lesions, thus bypassing the need for repeated biopsy. And it can also monitor the response to treatment, whether a treatment should be continued, stopped, or alternate treatment should be sought for. Then it can be used to take decision regarding biopsy. If, as explained above, while serial monitoring of skin lesions, if any dermoscopic signs show any warning, it can warrant biopsy. So it can help to take a decision regarding biopsy. Then dermoscopy directed biopsy. For example, if a lesion is larger, dermoscopy can give an idea about the area which is more representative of the pathology, from where we can take the biopsy. Then for digital consultation, dermoscopy helps in digital consultation. The image captured can be shared, which can be used for consultation or academic purposes, and hence it forms an integral part of telemedicine. Then other non-diagnostic application include, it can help us in seeking the endpoint of many therapeutic procedures, or then also after parasite extraction. Next. Dermoscopy of some common conditions. First image shows dermoscopy of plaque psoriasis, showing light red-pink background, red dots and white scales. Red dots represents tortuous capillaries in the papillary dermis. Then second is dermoscopy of a healing lichen planus lesion, with some active lesions in between. This shows reticulate Wickham striae, yellow structures, diffuse brown pigmentation, which is a healing area, and a violaceous background. Next. First image shows dermoscopy of lichen planopilaris, showing the double ring sign, perifollicular scales. Next is dermoscopy of tinea capitis, which is showing multiple black dots, comma-shaped hair, corkscrew hair, along with peripylar scales. Next. Dermoscopy of alopecia areata, showing yellow dot. Yellow dot is due to keratin or sebum in the follicular opening. Then black dot, vellus hair, broken hair, caudability hair, which shows kinking of hair when pushed perpendicularly, and tapering ends or exclamation mark sign. Next. Then dermoscopy of verruca vulgaris, showing well-defined margins, brown background, skin-colored papillae with red dots and globules, hemorrhage and interrupted skin lines. Dermoscopy of molluscum, showing central white structures of variable sizes in a polylobular pattern and mixed vascular pattern consisting of crown and radial vessels. Next. Then coming to pigmentary lesions, dermoscopy of melasma showing exaggerated pseudoreticular network in compared to normal pseudoreticular network. So the normal dermoscopic finding in the skin of face is pseudoreticular network. So in melasma it will be exaggerated. And there will be brownish dots and globules, and usually appendigeal openings are spared. Coming to dermoscopy of LPP, lichen planus pigmentosus, it shows diffusely distributed brown dots and globules showing perifollicular accentuation in some areas. Next. Nail fold capillaroscopy of a dermatomyositis patient. It shows dilated capillaries and tortuous vessels, and few capillary dropouts can also be seen. Coming to entomodermoscopy, dermoscopy of scabies. This picture shows dermoscopy of scabies. So it has the mite, scabies mite, jet with contrail sign, egg casings and scibella. Scibella is the feces of scabies mite. Next. Coming to malignant lesions, dermoscopy of BCC showing grey ovoid nest with brown peppering, blue-grey ovoid nest, blue-grey globules, blue-white veil, branching vessels and hemorrhage. Thank you.